All right, it looks like the numbers are holding steady right now, so respecting everyone's time, we will get started. Hello, everyone, and welcome back to the third session of Mini Med School 2022. My name is Kevin Field, and I am a fourth year student in the MD PhD program, and I, along with Nate Nelson Maney, one of the other fourth year students in the program, will be hosting you all tonight. We're really excited for both the student and faculty speakers. Just as a brief overview again of how we're going to run this, we'll have a short introductory talk by our student speaker, followed by a brief Q&A period. You can type your questions into the Q&A box and leave a little note. Depending on the time, either Nate and I can read it out for you, or we can unmute you to let you read it out yourself. Followed by a short break, we'll come back with Dr. Moll's talk and have another Q&A period after that. If you have any technical issues, please send an email to the UNC Mini Med School account, uncminimedschool@gmail.com. And without further ado, I will let Nate introduce our student speaker.
All right, thank you very much, Kevin. It is my distinct pleasure to introduce our MD PhD colleague, Zach Schrank. He attended Augustana College in Rock Island, Illinois in 2019, in which he graduated. He's now a first year in our MD PhD program, currently studying medical sciences in the classroom. His research focus is going to be in cancer biology with a focus on novel anti-tumor therapeutics. And with that, we'll let Zach start his talk.
All right, hey everybody, can you all hear me? All right, cool. Let me share my screen really quickly here. Let's try. Panels in the way. Okay, and can you all see this now? All right, and can you see my pointer? Okay, great. So hi everybody, thank you for that introduction, you guys. I really appreciate it. Again, yeah, I'm a first year in the MD PhD program, and it's been great so far. But today I'll be telling you a little bit about what clotting is, what's going on, and what can happen when it goes awry. So a really brief outline. First, I'm going to talk a little bit about what actually makes up our blood, and then I'm going to talk a little bit about the first stage of clotting, which is often called primary hemostasis, or the first thing that stops the blood, essentially. I like to think of it like a spackling of a wound shut, and I'll talk about that. And then we're going to talk about the second stage of clotting, which is sometimes called like coagulation or secondary hemostasis, and I think of it kind of like a net structure that gets formed. I'll then talk a little bit about how we break down clots once we're done with the repair process, and then what can happen when some of these components of clotting go wrong that leave us predisposed to clotting and bleeding disorders. So first, let's talk a little bit about what makes up our blood. We have these three predominant cell components. We have white blood cells, which are like our defenders of our blood. They fight off pathogens, and they come in various different shapes, sizes, and functions. We also have red blood cells, which function to deliver oxygen to the different organs in our body and keep them functioning. And then we have platelets, which kind of function to seal off damage to blood vessels and prevent us from leaking out all over the place. I wish I could have found another cute little illustration like these, but you get the picture. I think this is pretty cute too. So let's build a blood vessel really quickly and understand what is going on inside the blood. So you have your white blood cells, your red blood cells, and your platelets floating around. And in addition to that, you also have these molecules floating around amongst your cells in your blood. These are proteins, and the ones we're going to focus on are ones involved in clotting. Okay, so these are clotting proteins floating around. In addition to that, you can think of a blood vessel kind of like a pipe, but it's also lined with its own layer of cells too, called endothelial cells, which have important functions in a lot of different things your blood does. And it's also surrounded by this kind of like insulation almost material, kind of like a mesh. It's this fibery, cobwebby kind of material called its connective tissue. And it's also important in maintaining structure of the blood vessel, but it has factors inside it that are important for clotting that we're going to talk about too. So let's take our blood vessel and all the structure that it has, and we're going to take out the red blood cells and the white blood cells because they're not like super involved in the clotting process. So we're going to focus on the platelets and the clotting proteins. So let's say you're in the kitchen and you're cooking and you happen to accidentally nick your finger and cut yourself, and it nicks into one of your blood vessels. So you're going to have this opening in that wall, and you're going to expose some of that connective tissue that isn't normally exposed. Well, the reason you don't normally have clots forming all the time is because the stuff that it needs, the platelets need to bind to, is located in that connective tissue. And when you have a cut, you kind of expose it. And in addition to that, you also start releasing some other proteins into the blood that mix with the ones already there. And that's going to be important for the second part of the coagulation of clotting. But now that these signals are exposed, they're like beacons. The platelets can go and bind to this. And like I said, kind of spackle that wound shut. They start to aggregate together and attach to each other using this protein fibrinogen. And that's also very important for clotting as well. And so we have this like spackling shut of the wound, and this is primary hemostasis. And so next, we're going to talk about that net-like structure that I was talking about, where we really start to bundle these together with fibers and kickstart the wound healing process. So this is an image of the clotting cascade that scientists look at, but it's really complicated, and I don't even know if I know everything on there. So we're going to try and break it down to some more digestible components, okay? So you can think about the clotting cascade, if you will. It's like a series of events, kind of like a game of dominoes, where one domino starts and knocks over the next, and then the next one, and then the next one, activating each other in kind of a series. We can think of it like a game of telephone, where one person starts and then it continues to get passed along. It's kind of similar in clotting. So you remember I told you that when you have this wound, you kind of release these other factors into the blood that normally aren't there. And they're going to start to find their binding partners in the blood as well and stick together. And that's going to activate them. They're going to go and activate another guy floating around in the blood. They're going to go and activate another one. They're going to go and activate a different one, and so on and so forth until you get to the business end of the clotting. So these initial steps are all done by these proteins we call clotting factors. We've numbered them factors 5 through 12. And the specific ones are going to be important for some of the disorders, but right now that's a general overview of the cascade. So on the other end, we activate this guy called thrombin. And he's really important in turning that protein I told you about earlier, this black bar here that sticks those platelets together, fibrinogen, into fibrin. And fibrin is the structure that, or the protein that makes that kind of net mesh structure that all these cells can then start getting stuck in and form that clot that can help kickstart the healing process. And so it's important that we lay down that spackle in the beginning, because all of this process, or a good chunk of it, is happening on the surface of these platelets. And so this is a really nice coordinated process that we can get this clot formed and help kickstart healing. Now the question is, how do we stop this from happening just in general? Yeah, you don't have any of those connective tissue things normally exposed, but things happen. So how does the body keep you from forming clots just spontaneously? And there's proteins that are floating around in the blood to do that. One of those is protein C, and when it's turned on, it actually turns off one of those important clotting factors. It's actually factor 5, and essentially stops that cascade from continuing and prevents you from forming a clot inappropriately. And again, this is all primary or secondary hemostasis. Sorry, the bar got in the way. Yeah, secondary hemostasis. So what happens when we want to dissolve the clot? We fixed the wound, we've healed the tissue. What do we do next? We want to get rid of that clot so it doesn't obstruct blood flow. And that's called fibrinolysis, in a scientific term, but I think of it as clot busting. So let's say you form your clot. You also have another protein floating around called plasminogen, and it's normally not really active. There's another guy that gets activated or turned on called tissue plasminogen activator, or TPA. And this function is to activate plasminogen. It turns plasminogen on and turns it into this pair of molecular scissors. And what it then does is it goes and clips up the fibrin. It clips it up into little pieces and breaks down that net so you can dissolve the clot. And these little bits of fibrin are called D-dimers. And so you may have heard, if someone goes to the hospital or the emergency room, they might do a D-dimer test to look for these fragments of a clot forming that might suggest you've got a clot formed somewhere. And in addition, one of the therapies that can be done in certain cases for strokes when you have a clot blocking blood flow to the brain is to give TPA to try and dissolve that clot. So the question is, what can go wrong? especially from a clinical standpoint, that's often something that hematologists really are concerned about. So I told you about this cascade of events that we have, and all of these these clotting factors are coded in our DNA. So we'll say this gene here in our DNA codes for a good factor 5 or something. Well, what happens when that code gets messed up? Well, what happens is that we get changed versions of the protein, or sometimes we don't get any at all. And that can predispose us to clots, or make it so we bleed a lot, because maybe sometimes we can't form clots anymore, or we're forming too many when we shouldn't be. And so I'm going to talk about a few of those, just 3 of those right now. The first one is called factor 5 Leiden. And the V is, I'm terrible at Roman numerals, but I remember that one's 5. And so that's pretty, it's more common in groups that descended from like Northern Europe, like I think like Holland area. So it's more common in people of Northern European descent. And it's genetically inherited. But the idea is that you have a version of factor 5 that doesn't really get deactivated by protein C anymore. So protein C normally goes and interacts with factor 5 and shuts it off and prevents the clot from forming. But factor 5 Leiden is resistant to that. It stays active when it shouldn't and predisposes people to forming clots. And so this is a hypercoagulable disorder. The next one, hemophilia type A, is the opposite. It's more associated with excessive bleeding. And hemophilia A is when you have a deficiency in one of the clotting factors, factor 8. It's not really present, or it's present in very, very low numbers. And so when that happens, they're not able to continue activating that cascade, and you're not able to form clots when you need to. And so that leads to excessive bleeding. And oftentimes that bleeding occurs in your joints. And one of the therapies for this is actually just supplying factor 8 to these patients, which is pretty effective, but unfortunately is a pretty expensive option. And this affects about 1 in 5,000 male births in the US, according to some CDC statistics. I'm going to move my panel here really quickly. And the last one is von Willebrand's disease. And so it was discovered by a guy named Eric von Willebrand, and it's also a bleeding disorder. So von Willebrand factor is what's missing in this disease, or at least is in very, very low quantities floating around or present in the blood, or the blood vessels. So like I said, it also is characterized by excessive bleeding. And I told you about that signal the platelets first bind to, right? These guys right here, that's von Willebrand factor. And so when you don't have this present, your platelets can't form that initial kind of spackle structure. And so you're also predisposed to more bleeding as well. And so this affects about like 18 people per 100,000 people born in the US per year. And so, yeah, I got all these different panels on my screen, my apologies. But yeah, so there's many things that can increase your risk of clotting. Some that you wouldn't expect, pregnancy, that's another increased risk of clotting, and hormones associated with it. Surgery and immobility is something people often hear about, can increase risk of clots. And so a lot of things to consider. So that was a lot of really, I think it was interesting information, but I know it was a lot. So if anyone has any questions at some point, I'm happy to try and field those. But thank you guys for listening. And I really hope I was able to impart some interesting knowledge on you.
Zach, thank you. That was a wonderful talk and a wonderful run through on the clotting pathways that are active in our bodies. As a reminder to the audience, you feel free to ask questions in the question and answer box. Just type them in, and we can either unmute you if you would like, or if you'd like your question to remain anonymous, just please put that in the box, and Kevin or I can read it out for you. While we're waiting for questions to roll in, could you go back to the slide about the disorders, Zach? And actually, the question I was going to ask you is about this slide as well. So it's maybe a little bit of a trick question, because I remember from medical school something that one of our professors always used to say. But is there a prominent symptom that is associated with von Willebrand's disease that people might take for granted?
Yeah, so von Willebrand's disease, so hemophilia type A, like I said, is usually associated with like bleeding into the joints. But von Willebrand's disease, usually the bleeding shows up more what they call mucocutaneous. And so you get bleeding in tissues like, I think what you might be referring to is like really heavy menstrual cycles and like really heavy bleeding during menstruation. And so, I mean, if that's something that you've been living with, you might not know that like you're bleeding an excessive amount. And so I remember our professor, Dr. Ma, would tell us stories about women who she would see in the bleeding clinic who would, talk about management of their periods and how they'd be changing pads and having to put towels down while they're sleeping, while they're having their period, just because they bleed so much throughout the entire time. So I think that might be what you're getting at.
Yeah, that was exactly what I was getting at. Yeah. One of our professors, Dr. Ma, is that's a soapbox she likes to get on. So that would be important to talk about. We have a question from David Hack. Kevin, would you like to unmute him?
All right, it looks like we can't because David Hack doesn't have a compatible version of Zoom, but we can read that out. How common is factor V Leiden and what treatments are used for it?
Yeah, that's a good question. And honestly, I'm a little hazy on this, like the statistics of how common it is in the population. I don't know if Dr. Moll has any more insight on that and how common it is. And then in reality, from my understanding, you usually treat clots when they arise. I don't know that there's anything that people typically do to deal with the mutation itself. There is an increased risk of clotting, and I think it might just be something that you're aware of and deal with, and like take approaches to try and limit risk of clotting in other ways.
Zach, let me jump in there. So the frequency, so factor V Leiden occurs in 5% of the Caucasian background population, 1 in 20 people. So it's really common. And it's a mild risk factor for blood clots. Most people never develop a clot if they only have 1 gene. If you have 2 genes, you're homozygous, abnormal, then the risk is somewhat higher, but still many people don't clot. And regarding what treatment to use, you're correct. Typically, if somebody has factor V Leiden, you wouldn't even know it, and we don't go routinely testing for it. And if you find it, most people don't get treated unless they have had a clot. And how we treat blood clots, we'll talk about in the second part of our presentation.
Awesome, thank you. We've also just had a question come in from somebody, from Barbara Hummel. But since you hinted that we talk about the resolution of clots in your talk, we might wait to answer that question. See if your talk answers that question. Additionally, a caveat, again, to remember is that nothing we offer here is actually medical advice. You should always speak with your own physician in a clinical setting to find out the best course of action for your clinical situation.
Nathan, let me just to get this out of the way, because it's a really good question that Mrs. Hummel has, or Miss Hummel. So blood clots are typically multifactorial. It's not just one thing that makes people clot. And Zach presented many different reasons, such as birth control pill, elevated estrogens, pregnancy, immobility, surgery, trauma, long distance travel, hospitalization. So really the key in somebody like you is to identify all these different risk factors in an ABC manner that you don't miss any of the risk factors. It would be inappropriate to simply focus on the factor V Leiden because it is typically multifactorial. And then you can determine which of these risk factors was transient, such as long distance travel or hospitalization or trauma, and which ones are more permanent, such as the factor V Leiden, or maybe obesity with a body mass index of 35, or a family history in your first degree relative, a brother, or maybe a dad or a mom. And that really then determines how long to treat with blood thinners. Is it a transient risk factor, 3 months, independent of factor V Leiden or not? or was it an out of the blue, unprovoked, or a clot with permanent risk factors, and you typically treat long term. And then it's only occasionally that we use the clot busters that Zach showed in his presentation, which is called TPA, that we can give as a medication, and it immediately tries to dissolve the blood clot, but it has a risk for significant bleeding, including risk for bleeding into the head. But once you're on a blood thinner, the blood thinner prevents extension of the clot so that it doesn't get bigger. And then your own body kicks in with the TPA enzyme that Zach showed, that we all have, that starts to clip away those fibrin structures. And then over time, your own body will start to dissolve the clot. In some people, very successfully. In some people not so successfully, and they develop some scar tissue in the legs. But it does, your own body starts to dissolve the clot.
Thank you,
All
Dr. Moll. That was a great answer.
I think we've got one more question before the break, and Jane, I can unmute you, let you talk.
Jane, you should be able to unmute and speak now, but we can read out your question. Jane's question was, why does D-dimers elevate during severe COVID, and how are blood clots related to this?
Yeah, that's a good question. I'm not super versed in I know that there's like an association of clots with COVID. And so just having clots present is usually going to increase your D-dimer, just because you have a bit of fibrinolysis happening. But as far as the association with COVID, I'm not 100% sure. Maybe Dr. Moll might have a better understanding of that.
And Zach, your images really explain it already. In COVID-19, you have COVID infection, you have damage to the blood vessels, particularly in the lung, because the endothelial cells, the layer of the blood vessels in the lung get damaged, and then the body tries to fix that with little clots, and they get broken down immediately, so the D-dimer goes up. The D-dimer is not necessarily a sign of a big clot, but can be elevated in small clots, but it's also elevated in inflammatory disorders, in trauma, in liver disease. It's very unspecific.
All right, thank you. I think with that, we'll do one more question and then go to break. And this is a question that I was actually thinking earlier when you put up those stats, Zach. So it says that hemophilia A affects 1 in 5,000 male births. Is it more common in men? And if so, why?
Yeah, so I believe hemophilia type A is X-linked. And so people who are born with an X and a Y chromosome have, one copy of the X chromosome. So the gene that you're looking at is on the X chromosome. So if it's messed up in someone who has 2 X chromosomes, then you still have one that's good. But if you have somebody who has an X and a Y chromosome and you have the X chromosomes messed up, that's kind of all you've got. And so that's why it's more common in men or people who have XY chromosomes.
And that's a good explanation. And then you can add to it, women can be carriers of it because they can have one abnormal X chromosome, and they may have slightly lower factor VIII levels, but not low enough to bleed. But since it's abnormal, they can pass it on to their offspring, so their son could have hemophilia.
Yeah, and I believe some women can actually be symptomatic when they're carriers as well, because they do have one of them that is inefficient. So you can think of it, they almost have essentially half of what they normally would have. And so that can sometimes manifest as bleeding.
Correct.
All right. Thank you to Zach for really great introductory talk. I think we'll take about a 5-minute break and come back at 7 p.m. so that Dr. Moll can begin his talk.
And please tell me, do you see my screen?
Yes, we
Yes.
do. And we've got the laser pointer too.
Superb. And thank you everybody for who's on the call. And please feel free to ask questions and interrupt during the talk. I want to talk about blood clots and some of the basics. And this is hopefully relevant for patients on the call, family members, but also for the upcoming MDs here that we're interacting with. So let me just see. I'm going to talk about what are blood clots clinically, the diagnosis, how to make the diagnosis, treatment, then some research topics, and there will be time for question and comments. And just briefly who I am, as you may tell from my accent, German. I went to medical school in Germany. I trained clinically partially in England, and then I did my residency and fellowship. That is my internal medicine and hematology oncology training at Duke. I've been on faculty at UNC for the last 20 years. So I'm really a hematologist. I don't deal with leukemia and lymphoma, but what we call benign hematology or non-malignant hematology. And blood clotting and bleeding disorders are part of it. The other parts are anemia and high and low blood counts. So the clotting specialist with bleeding and clotting disorders is called a coagulationist. My other two activities are I have a family and I'm a wood turner, and I'm trying to balance these three things. What I like about being a coagulationist is, as Zach indicated earlier, this clotting cascade that you saw with all those clotting factors. Most people don't really understand how it works and get overwhelmed by it. There are multiple medications that work in this cascade. There are multiple clotting tests that one can do for bleeding and clotting disorders. And to interpret those is challenging for many physicians, appropriately, and that's okay. And they turn to the coagulationist. So I often feel, and I'm serious about that, like we're in the middle of medical care in the hospital, because cardiologists see people with heart attacks that are unexplained. So they wonder about a clotting issue that led to the heart attack, or strokes in neurology patients. And then there's some pregnancy complications where, like HELLP syndrome or preeclampsia, where clotting plays a significant role, and we get involved in that. General medicine sees people with clotting disorders, surgery, the emergency department, etc. So I like that because you interact with the specialties, you learn from them, you're able to give them assistance, and it's a good collaboration. And then on top of that, there are parts in the hospital that ask for your help, the quality improvement office for algorithms in clotting disorders, the pharmacy, which drugs should we have on board, which should be limited to certain people, the guidance development, how do we treat bleeding disorders so that we don't waste blood thinners, blood reversal agents, and that we use them appropriately. And then obviously the legal office, every so often, if something that doesn't go right or people think it didn't go right, it needs to be clarified, was it standard of care? Family, just to briefly mention that, since the MD PhDs, you guys are high-powered people, and it's difficult to have a balance between a profession that you like and a family. And I have 4 daughters. This is an image when I was a junior faculty member. This is an image last year. I have now 4 teenagers, and in the middle is my wife. And then finally, what gives me some balance in the last many years, I'm a wood turner. I have a lathe. I like to turn bowls and such. And that's a big hobby that takes me away from everything. Here are a few things that I have done. And I'm on Instagram, which can be, if you like, scanned here, and you can see what I create. By the way, this here is a scar that I got last year in a piece of willow oak from East Rosemary Street, from North Boundary Street, flew off the lathe and hit me on the head and took me into the emergency room at UNC. It healed okay, and I think I didn't take any damage. My wife says I was like this before the injury. Be that as it may, safety is really key, and those were unfortunate circumstances that led to that. So having introduced you to who I am, what are blood clots? And Zach used these terms more in the physiological and pathophysiological way. I'm going to use them in a clinical way. First of all, let's define it. Thrombus, in plain English, is a blood clot. DVT, which we'll talk about, is a deep vein thrombosis. And that's mostly a blood clot in the legs, in the deep veins of the legs, the major veins. Typically, leg can be in the arm, can be in the abdomen, can be around the brain. That's a DVT. PE is a pulmonary embolism. That's a clot in the lung. And then VTE is a venous thromboembolism. And that's really the overall term for blood clots in the leg, or a DVT and a PE. So we're going to talk about VTE, the DVTs and PEs today. We're not going to talk about arterial clots, heart attacks and strokes. They're in arteries. We're talking about clots in veins. And an embolus is a clot that has traveled. So DVT in the leg, if it breaks off, it travels through the bloodstream into the lung, and then it's called a pulmonary embolism because it traveled. And for the anatomy's sake, just briefly get that out of the way. The blood flows to the arteries, through the capillaries, delivers the oxygen, and then returns to the heart through the vein. And the clots in the arteries that we will not talk about, but that many people think about when they hear blood clots, those are, if they're in the leg, called leg arterial clot or gangrene. The blood cannot flow into the leg, so there's oxygen, lack of oxygen, and the leg becomes painful and pale, laid on black. It's a bad term, it dies, or it's an impressive term, but it's extremely painful. And then sometimes it leads to leg amputation. If a clot happens in the carotid arteries or further up in the brain, that's a stroke. That's typically an arterial event. If it's only a small stroke that goes away, the symptoms go away within a few hours. It's called a TIA or mini stroke. And again, we're not going to talk about that much. Heart attack is a clot in an artery of the heart muscle, the coronary artery. And again, that's an arterial event. Venous clots, and that's what we have today. DVT right here. There are 4 symptoms, and everybody, medical or not medical, really should know about them because DVTs are pretty common in the general population. And there are 4 symptoms. And imagine the blood still is pumped into the leg, but it cannot come out. So pump into the leg swells up, swelling is painful, blood is warm, so the leg may be warm, and blood is bluish, so the leg may turn blue or purple. Those are the cardinal symptoms of a DVT. Sometimes it's only swollen and painful. Those are the classical symptoms. We mentioned if the clot breaks off, then it goes through the chamber of the heart into the lung. And that's a pulmonary embolism. Again, 4 symptoms: shortness of breath, chest pain. And the chest pain is typically when you take a deep breath in. And it hurts when you take a deep breath in. And then again, it's not just for a few seconds. This is for hours or for a few days. And then there may be a cough. People may cough up blood. And there may be a fast heart rate without the patient doing anything at rest. That's a PE. Now, if you know the anatomy, and it's important, if a DVT breaks off, it lands in the lung, it does not go to the brain. There are a few rare circumstances, but a DVT does not lead to a stroke. And that's important and often reassuring for the patients. And a DVT does not lead to a heart attack either. It does not lead to a coronary artery clot, because that's a clot in an artery. And why do clots form? Zach talked about some of the different clotting disorders like protein C deficiency or factor V Leiden. Now the artery clots, and this is my last, I think second to last slide on artery clots, those artery clots are due to plaque, arteriosclerosis. And that's on top of that, a blood clot forms, and that leads to the stroke or heart attack. And the arteriosclerosis, the plaque, is due to, as you know, cholesterol or cigarette smoking. Obesity is a risk factor, high cholesterol. The vein clots are completely different because the vessel wall is different. Arteries have thick walls. There's high pressure in the arteries. Veins have thin walls. There's low pressure. So the blood vessel wall does not play all that much of a role in causing clots. It's more the clotting disorders that we mentioned. And it's where the blood doesn't flow right, like what we call stasis, like immobility in the hospital. You're immobile in the hospital bed, or surgery. The patient after surgery is not mobile. But surgery can also cause blood clots because it damages the blood vessel wall. Different etiologies, causes of the clots. And I've listed that here: artery clots, typically smoking, overweight, cholesterol, high blood pressure, diabetes. Vein clots, immobility, overweight, surgery, trauma, estrogens, pregnancy, cancer, and the clotting disorder, like Mrs. Hummel with the factor V Leiden that you mentioned. And they can be either inherited or can be acquired. So this then also determines what drugs we use to treat the blood clot or to prevent a recurrence. And the artery clots are made up out of platelets, these little yellow platelets, and fibrin that was mentioned. So if you want to prevent an arterial clot, you may want to block either the fibrin or the platelet. And the antiplatelet drugs are aspirin, Plavix, and Ticlet, Argonox, and a couple of others. The most common one is aspirin and sometimes Plavix. So after stroke or heart attack, people are typically put on aspirin because it prevents the platelets from sticking together, the aggregation that Zach mentioned, and thus protects people from further arterial events. There are also some natural blood thinners. They typically work on platelets. Whether they have clinically any positive effect is unknown. I would not put much stock into them. If somebody has had a heart attack or stroke, they should be on a real strong antiplatelet drug like aspirin. The garlic, ginkgo, vitamin E, on so-called natural antiplatelet agents. Now, you could also use a real blood thinner. Blood thinners are the ones that inhibit this fibrin, or that prevent the fibrin from forming. And those are heparin, that is given into the vein or into this fat tissue, warfarin, also called Coumadin or Jantoven, and then the somewhat newer drugs called Pradaxa, Xarelto, Eliquis, and Savesa. The most commonly ones in the US are Xarelto and Eliquis. Now, they would to some degree also prevent arterial clots, so they might be good for stroke or heart attacks, but they have much higher risk for bleeding than aspirin. So with stroke and heart attacks, it's typically aspirin that's being used, or Plavix. Low risk for bleeding, high efficacy. Now, some of the strokes, and this is where it gets a little more complex, some of the arterial strokes are caused by atrial fibrillation, where the left atrium has a flutter or fibrillates, and the blood doesn't flow right because it doesn't contract regularly, and then clots can form. Those atrial fibrillation patients actually do get the real blood thinners because the mechanism of clots in the atrial fibrillation is similar to the mechanism in veins, where the platelets don't play much of a role, but the fibrin protein. So then the vein clots that we'll talk about now from now on, you typically use a blood thinner because there are very few platelets in these clots. The clots are made up mostly out of fibrin. So you would think aspirin is not very effective. Plavix wouldn't be. Garlic, ginkgo doesn't do anything. So the real blood thinners I've mentioned, and nowadays for DVT and PE, we classically use the ones in green because they're much easier to take. They don't need to be monitored compared to warfarin or Coumadin or Jantoven. And we typically use in the US Xarelto and Eliquis for marketing reasons. Pradaxa could be used. The Japanese drug Savesa could be used. They've been tested, FDA approved, but this one is not as widely available. This has some downsides because it's cleared in the kidney more than the others and has some gastrointestinal side effects that these two typically do not have.
Dr. Moll, we actually have our first question.
Yes, and I don't see them because I've done away. Oh, okay, I see it right here.
So why do hip replacement patients need to take anticoagulation medicines? If DVTs don't lead to strokes, what risk are the medicines reducing?
Appropriate question. They decrease the development of DVT and PE, of the vein clots. The patient had surgery. Surgery is a risk factor for DVT. The patient is immobile, is hospitalized, and had trauma to the blood vessels. So they are all risk factors for DVT. So the blood thinners being used are typically either the shots called Lovenox, enoxaparin, or Fragmin, or maybe the oral drug Eliquis and Xarelto to prevent DVT and PE.
Yeah, and I think for everyone in the audience, it's important to remember that strokes are a major cause of death. They're really important, especially in the South, but DVTs and PEs are also really bad, and you could die of a PE potentially if it's untreated. So it's important to prevent those as well.
And Ms. Twing is asking a question, and it's a good question. I would like to get away from the AFib because there's so much to talk about DVT and PE, and that was our focus. There's a lot of cardiology issues, so my apologies for that, but maybe a future event could be on atrial fibrillation and arterial events. So at this point, my take-home point or key point would be that aspirin and similar drugs like Plavix are not very effective in preventing vein clots. So imagine you want to fly from here to New Zealand and you're immobile, so you're at risk for DVT. Maybe you are also overweight or obese, and maybe you're a woman on estrogens. You're at risk for DVT, and you wonder, would aspirin be beneficial to prevent the clot? And the answer would be highly likely not. Aspirin does not have much effect preventing DVT. If you're at high enough risk that some treatment is needed, then it should be something like Eliquis or Xarelto or a Lovenox shot before the long distance flight. And then I encourage everybody to know your DVT and PE risk factors, cancer, surgery, immobility, hospitalization, overweight, estrogens, and family history. Family history. Know whether your dad or your aunt had a DVT or PE. So then, let me just see. Here we go. Just to get a few things out of the way. This is a spider vein, and Kevin Field was generous enough that he allowed me to take a picture of his thigh here. Just joking, Kevin, you know, everybody. These are spider veins. They're little widenings, dilatations of the veins in the skin. They're clinically irrelevant. They may be viewed as unsightly, but they do not predispose to any medical issues. They're not risk factors for superficial clot, for varicose veins, or for deep vein thrombosis. Varicose veins that some people have, and I think you can see here these sausage-like structures underneath the skin. Those, and that's what it looks like, those veins are widened and the valves don't work right. And people can clot in those, and that leads to a superficial clot. Superficial clots are typically not dangerous. They don't break off, don't go to the lung, but they can be extremely painful. That's a superficial thrombophlebitis. But sometimes varicose veins for years don't do anything, so they do not need to be treated. But if they're unsightly, certainly the vascular surgeons and vein clinics can deal with that and get rid of them. We don't need them. And then the superficial thrombophlebitis that I mentioned, those are the superficial skin veins, such as what you may see in your hand. They can get inflamed and they can clot. And the symptoms are pain, redness, warmth. You can feel the clotted vein. They can be extremely painful, but they're always focal in one specific area. They can be long and short, but it's not the whole leg involved. And in a deep clot that we'll talk about in a second, in a deep clot, you cannot feel the clotted vein because it's so deep inside. The superficial clot you can feel. These clots, we sometimes treat with blood thinners for a short period of time to avoid that they get bigger. But the symptoms typically go away within 2 weeks by themselves. And we use ibuprofen, Motrin, anti-inflammatory drugs, and blood thinners only if the clots are pretty severe. So this is the treatment here. Some people apply heat or cold, whatever makes the leg feel better, and then occasionally short-term blood thinners. Now, this is the real medical issue where treatment is absolutely needed. And this is an extreme example. And I have the permission, when I use these images of medical images, I have the permission of the patients to show them for educational purposes. Now, this woman comes in with a left leg swelling that's quite severe. I think you may appreciate that it's reddish right here. It's shiny because it's swollen so much. That is painful. And that the foot is swollen. that eventually, if you do the imaging study, is a DVT that's quite extensive: pain, swelling, discoloration, and warmth. You also see that this leg that is not swollen has discoloration right here. And she had a clot, a DVT in this leg a few years ago that healed up. The leg became swelled down again, became normal, but you have some pigmentation left that's called post-thrombotic syndrome. That's clinically irrelevant. It just shows that there was a clot in the past. And the symptoms, as opposed to the superficial clot, the symptoms are diffuse. It's the whole foot, the whole ankle, the whole foot plus the calf, diffuse, and you cannot feel a cord. This is another patient who is then diagnosed with a DVT. She comes in with right leg swelling. And I think you can appreciate how this is significantly swollen compared to this one. And it's reddish discolored. And when I press with my fingers here on the outside of the thigh, it depresses, it stays depressed. That's edema, swelling, fluid retention. There's a high suspicion that she has a DVT, and the Doppler ultrasound imaging then shows she has a DVT. And this is yet another one. She has left leg swelling, and I think you can appreciate the kneecap is easily seen here. A little more difficult to see here. She has thigh swelling, some calf swelling, but she's able to stand. So DVTs can be very mild, very subtle, moderate, or can be severe. Pulmonary embolism, I talked about how it goes through the chamber of the heart into the lung and gets caught up in the lung. And we've discussed the symptoms: chest pain, shortness of breath, cough, unexplained fast heart rate. So my key point about these things is, for everyone, particularly the ones who have some risk factors, be it a family history, obesity, who are traveling long distances, who are on birth control pills, know the 4 main symptoms of DVT and those of PE. And I've repeated them on purpose to think 4 leg symptoms, 4 lung symptoms. Make sure your family knows them, particularly somebody like Miss Hummel. If you have siblings or children, make sure they know what the symptoms are, because they are at slightly higher risk if their family member, you in this case, had a blood clot. So they want to be proactive if those symptoms come up. And we've created this bookmark from our Clot Connect program, which lists the symptoms of DVT and the symptoms of PE. And if anybody ever has an idea or thought, well, I would like to take this up as a project to raise awareness, certainly we could talk about that. Symptoms can be very subtle. They can be acute, come up within 24 hours or less, or they have a slow onset over several days or weeks or sometimes months. And people don't think much about them until they get worse and worse and they don't go away, and then they eventually get diagnosed with a DVT. Now, 50% of patients who have a clot in the leg, DVT, also break off little pieces and have a DVT. And sometimes they're larger. The small ones are without any symptoms, are clinically not relevant. The larger ones may also lead to shortness of breath and chest pain. And then many patients who have a PE have a DVT in the leg or pelvis, because most PEs come from somewhere downstream from the legs. So that's the basics about DVT and PE. And if you ask, is this topic relevant? Well, the ones who have had a clot know it's relevant, but by numbers, it's a pretty significant issue. And I've calculated here, North Carolina, every year, 30,000 people have a DVT and PE. And this is based on CDC data. And you can pull up this article. It talks about how many people in the US have DVT, PE every year, et cetera. So based on the population of North Carolina, 30,000 people with DVT or PE, that is, leads to 10,000 hospital admissions per year. That's quite a lot. And it leads to 10,000 deaths per year in North Carolina, or 30 deaths per day of PE in North Carolina. That's a lot. So it's a pretty significant issue. And how does it get diagnosed? Well, there are typically 3 things that we do in medicine. We take a history, we do an exam, and then we do imaging or lab testing. And really the medical history when the patient presents focuses on the risk factors in the last 3 months. Have you had major surgery? Have you been in the hospital? Did you have long distance travel? Have you been on birth control pills? And then other things in the history. Do you have a family history of blood clots? Have you had a clot before? And physical examination. In the case of DVT, we measure the leg. We look at it. Is it warm? Is it red? What's the circumference in the calf? And then we do, if there's high suspicion for a DVT, we do an imaging study. That's a Doppler ultrasound, also called a duplex. We rarely do a CT or MRI or contrast venogram, even though those could be done, but a Doppler is easy, no radiation exposure. Now, Zach mentioned that sometimes you could use a D-dimer in the lab or clinic. So the D-dimer we only use if we have somebody comes with leg symptoms and we think, yeah, this is probably not a DVT. And rather than immediately rush into getting a Doppler, if we have a low pre-test probability, then we can get a D-dimer. And if the D-dimer is negative or normal, that's good. Then this is not a DVT. We didn't think it was a DVT, plus the D-dimer is negative, we are done. But if the D-dimer is positive, then we need to get an imaging study because then it could be a blood clot. And that's the use of this pre-test probability assessment that limits the use of invasive or more elaborate tests because some people, they just have an ankle pain and you don't need to get a Doppler immediately. So that's a Doppler. And then here, this is the vessel. Black means there's no flow. That's the clot. Where there's flow, there's color going two different directions. This is the artery right next to it. There's good flow in the artery. And this is a DVT in a deep vein. And then the Doppler tech writes, somehow describes or has an image how extensive the clot is. And DVT is typically quite extensive. That's just natural. This is a moderate sized DVT. Arterial clots, the stroke, heart attack, coronary artery clots, those are tiny because a tiny clot occludes the artery and leads to stroke and heart attack. The vein clots, because the blood cannot flow anymore towards the heart, there's just stasis and the clot gets bigger, bigger, and bigger and extends either downwards or extends further upstream. PE, same thing. We take a history, we focus on the risk factors in the last few months. We examine the patient, we listen to the lung, we examine is any cancer, evidence lymph nodes, because cancer can often predisposes to DVT and PE. And then if we think this could well be a PE, we get an imaging study. And the test of choice is a CT of the chest called a CTA, CT angiogram. And that's what you see right here. It's a cut through the chest. You have the lungs, the black areas, lung here. This is the big pulmonary vessel that leads the blood into the lung. The left side here, or on your image, the right side, this is all white, that's contrast, it looks open. This one here, look, this black, brownish thing here, that should be white, there should be contrast. This contrast filling defect, that's a big PE, very symptomatic. And sometimes people do a VQ scan, not often. The chest x-ray is not helpful. The chest x-ray is almost always negative in case of PE. So that's an important point. And then people like Ms. Hummel and others will, I don't know whether Ms. Hummel reports that, hopefully not. Hopefully you were diagnosed very quickly, but because symptoms can be so subtle and people don't think about blood clots always, particularly in the youngish people, they may think that the DVT symptoms may be Charlie horse or muscle cramp or muscle tear or sprained ankle. And then the physician may say, just take an ibuprofen and rest it and see over the next few days how it develops. And if it's really a DVT, then the DVT may get bigger or a PE may form, and the waiting is not the right thing to do. But as I mentioned, you don't want to rush into too much testing. And that's really where the D-dimer plays a role. If the suspicion for a DVT is not very high, then a D-dimer is appropriate. But it's important for the patient to know what your risk factors are, because if you already have risk factors, you are on the birth control pill and you develop leg symptoms, and there is no preceding trauma, that could well be a DVT, and physicians may not recognize that. So the patient should have should be self-assured enough that they could suggest, could this be a DVT? Is it appropriate to get either a D-dimer or a Doppler ultrasound? So patient autonomy, I'm a strong proponent of that, educated patients, because our medical care, unfortunately, there's quite a bit to be desired. There are many subspecialists these days. Some areas are not that well trained. We are very fortunate here at UNC and with Duke next door, but good care is not to be had everywhere. And there are many hurdles for good clinical care, including finances, but we're not going to go there. So this advice, if it's really a DVT, the rest, take Motrin and see me back if it's not better in a week, may be appropriate if it's truly not due to a DVT, but maybe bad choice. PE is often, or is also not infrequently misdiagnosed. If the symptoms are subtle, the physician may say, oh, it's a touch of pneumonia or some bronchitis, give antibiotics for the shortness of breath. Or for the chest pain, it's musculoskeletal, you just kind of tore something. Or it's an adult onset of asthma, which barely ever exists, that shortness of breath suddenly occurs during adult life. So again, it's important to know what your risk factors for blood clots are to make the physician aware, well, maybe it could be a PE. And the advice that people may get badly is to take antibiotics, take Motrin for the musculoskeletal pain, or see me back if the pain doesn't get better. That was part 2, treatment, diagnosis.
Dr.
Kevin
Moll,
or Nathan, any questions on those issues?
Yes, actually, Dr. Moll, there are 2. One person asked a question about platelet-rich plasma causing DVTs. And then a second question is, how do compression stocks reduce the risk of DVTs during long airplane trips?
Yeah, so plasma, platelet-rich plasma, the orthopedics use frequently, and I have not seen convincing data that it does increase the risk for DVT-PE. Now, the joint injury itself may, because the patient may not be as mobile, may have a boot immobilizer or a knee stabilizer, but the plasma-rich, the platelet-rich plasma by itself, I have not seen convincing evidence. And then there was a second.
The second question was, how do compression socks reduce the risk of DVT in travel?
That's a really good question. You might think we know that, and we don't really know. The same is true with compression stockings or the TET stockings in the hospital that sometimes still get used, but typically not anymore. There's some theory, well, number one, you have less stasis when you travel, for example. You prevent the swelling, and there's better blood flow back to the heart. But that's not really much of the case. It's much better to use your foot pump so that you really pump blood up. There's some theory that compression stockings increase fibrinolysis, and that's what Zach presented, the clot dissolving mechanism with a TPA, that there's a stimulation, but really the mechanism is not well known.
Thank you for those great questions and the great answers.
Terrific. Treatment. So let's see here. There we go. Treatment. Clots can often be treated as outpatients, and it's clearly true for the DVTs, unless they're really significant with lots of pain, and maybe if they're really significant, there needs to be a clot buster that vascular surgery or vascular radiology wants to give, or mechanical thrombectomy, mechanically removing the clot. But a moderate-sized or mild DVT can be treated as an outpatient. And that has actually led our hematology group to create a so-called DVT walk-in clinic, where patients with newly diagnosed DVT get seen within typically 24 or 48 hours. They don't need to go to the emergency room. whoever diagnoses them gives them a blood thinner for the first couple of days, and they can call our the person who runs this, who's Cassie Frank, our physician assistant, if they don't know what blood thinner to use, etc. And then we can see them within 48 hours and talk more about what to expect, how active to be, what blood thinner to use, what labs need to be done, how long to treat, etc. That's a DVT walk-in clinic with Cassie Frank. And then the clot busters or lytic therapy, TPA, that's only considered really in very significant clots. And there's been a trial called the ATTRACT trial that showed it's beneficial in people with a very extensive clots. And then you put people on blood thinners. And the purpose of the blood thinner is not to dissolve the blood clot. That's not what blood thinners do. The blood thinners prevent clots from getting bigger. And then your own body starts to dissolve blood clots. And the blood clots that used to be used was warfarin. First one used this shot of Lovenox or heparin until the warfarin became active. It takes 5-7 days. And then one thinned the blood to a certain level, and this value tells you how thin the blood is, cumbersome, because everybody needs a different dose, because we metabolize warfarin different. It's influenced by diet. People need to go to the physician to get it tested. Not used all that much anymore. The newer blood thinners, and they're still often called newer, even though they've been around now for 8 or 10 years. Those are Xarelto, Eliquis, Pradaxa, Savesa. They're also called DOACs, direct oral anticoagulants. And I'll use this term down the line, DOACs. They are a fixed dose. You don't need to monitor them because people metabolize them relatively predictably. So more or less one dose fits all. That's good, makes it easy. And they're not influenced by anything in the diet, vitamin K or other foods. And other medications influence the DOACs much less than they influence warfarin. So they're great choice. They also have a little bit of advantage regarding major bleeding risk, less major bleeding risk. So the guidelines and guidance documents from societies recommend to use one of the DOACs rather than warfarin. Cost is another issue, and we'll talk about this in a second. And then one of the major questions that come up to the hematologist in clinic is, how long do I need to be on a blood thinner? And Ms. Hummel will be wondering about that in her situation probably too. And it's really important, the length is determined by what caused the blood clot. Was it a major surgery, major immobility, major trauma? You treat with 3 months or maybe 6 months, short term, and then you stop, and the risk for future clot is low. But if the clot came out of the blue or has a permanent risk factor such as cancer, which is not going to be cured, people get treated with long-term blood thinners because they have a high risk of blood clot recurrence if they come off. And that's something that we need to go through in clinic. And that's where we list all the risk factors as A, B, C, D to think about them all individually. The DOACs, I've mentioned them. They're attractive and they're a good choice and most commonly used these days. And what I do is when I see patients on blood thinners at 3 months or 6 months, I ask them about their warfarin hate factor on a scale from 0 to 10. How much you hate to be on warfarin? 0, it's just a pill, no big deal. 10, I hate it incredibly, I need to come off. And then patients typically spill out why they hate it so much, the monitoring, the needing to go to the physician, the interaction with other drugs, this instability of this INR value, how thin the blood is, and maybe the interaction with food. And then I ask them about the hate factor for Eliquis and Xarelto and Pradaxa, and ask them specifically, what is your copay, your cost? Because that is the main hate factor, because they are not inexpensive. It's all out of the pocket or a big copay. But, and I wish this would go out more into the medical community, emergency room community, as well as patient community. All companies making these DOACs have patient support programs where patients can often get the drug for $10 a month as a copay. Unfortunately, this is does not grip for people who have Medicare or Medicaid or TRICARE, the military people, or who have no insurance. It's only for the people who have some private insurance. But still, the copay for those people could be high, and they can get it for much less, $10 a month, typically in the first year, sometimes the second, sometimes in the third year. But if a patient has no insurance, many hospitals have patient support programs, charity care. UNC has a big charity care program. So we get our pharmacists involved in the DVT walk-in clinic to talk about cost of the drugs and to make sure that the patient can afford the drug. Important. And then what do you expect after you've had a clot? How quickly do you improve? And that really depends on the individual patient. Some people improve quickly within a few days, being on a blood thinner. Oh, I feel better after 2 or 3 days. And some people it takes slower, a week, 2 weeks. And often it takes several weeks to get back to normal, but not everybody gets back to normal. There can be complete recovery or incomplete. Some people have chronic leg swelling, leg heaviness, leg tiredness, and that's called post-thrombotic syndrome. And there's no prediction who will recover completely and who will not. The majority completely recovers, but not everybody. And you follow patients over time. Activity, how active to be after blood clot? Well, if you walk and do things, you don't increase the risk for the clot breaking off. So we recommend that people be as active as they feel comfortable. If they have pain, don't be active. But if you feel good, it's fine to go back to work or to do what you like to do. And if you're an athlete and really like to push it, by 4 weeks, typically people can be back to full activity level. I do tell patients in the first 4 weeks, take it somewhat easy. This is, in a big clot, significant trauma on your body. You want to heal from it. And you don't want to go run a marathon within 4 weeks with a bang, bang, bang. That may actually, we don't know, but it may lead to clots breaking off more easily. And then some people ask, do I need a regular follow-up Doppler ultrasound to see how the clot is developing? And the answer is no. What counts is the clinical improvement. A repeat Doppler ultrasound, we only obtain if the patient develops new symptoms, or maybe at 3 months or 6 months when we stop blood thinners. And we don't do the Doppler to determine whether we should stop blood thinners. We get the Doppler ultrasound to get a new baseline so that at the time the patient comes off blood thinners, we know what is left over clot and scar tissue, so that if problems come up a year later, 2 years, we know this is new since you came off blood thinners. And then we've created, a coworker and I, this brochure of questions that patients typically ask, deep vein thrombosis and pulmonary embolism information for newly diagnosed patients. It's available on the web, on the Clot Connect website, and you can certainly screen here the QR code, and it takes you immediately to it. My dream when I was younger, 10 years ago, was that every patient in the United States with newly diagnosed DVT or PE would have access to this brochure. And I tried to get the pharmaceutical companies that make the blood thinners to print it and have it with their drug or some other mechanism, and I did not succeed with that. I've put it on the web, I give it to our patients in the DVT walk-in clinic, but I really wish everybody had access to it, because what we discuss is what you see here on, let me see here. It talks about the treatment, the different blood thinners in patient language. It talks about the common questions patients have. When will my clot and my pain go away? It has a graph at the end where I draw in where the clot is. And there are many other issues that get addressed on these 32 pages. So if any of the young MD, PhDs, anybody wants to take this on as a project, we can talk about it. I have a lot of experience what did work and particularly what didn't work. But really, patients are typically very thankful to have this information. It's more than the bare bones that the pharmaceutical industry puts out on their website, where they really don't have much clinical information. But there are 3 websites that I do want to mention. The Clot Connect website that we founded in UNC, and there is a nonprofit organization in the US that has existed for 15, 18 years, stoptheclot.org. It's a nonprofit patient organization, and I'm a co-founder of it, and I believe in the organization as a shaker for activity in Washington, D.C. with the CDC to just get the message out, even though a big national nonprofit, if you've ever worked in them, whoa, they also have bureaucratic hurdles, and it's difficult to work with a nonprofit organization. It can be very difficult. And then there's an awesome professional nonprofit organization. So particularly the MD, PhD folks who get into thrombosis, anticoagulation, the Anticoagulation Forum is a very effective, well-run organization with superb people, great networking. AC Forum, highly recommend it. And then I mentioned to you a question that really is a key one in the hematology clinic is how long to treat with blood thinners. And that really depends on, as I mentioned, what were the risk factors for the first clot and what are risk factors for recurrence. And that's why we identify in an ABC pattern what caused the first clot. We weigh it against the risk for bleeding, low platelets, hemorrhoids, has had a major gastrointestinal bleed before, needs to be on aspirin because of a previous history of a heart stent, etc. And then the third one is the patient preference, which I assess, as I mentioned, with the warfarin hate factor and the Eliquis and Xarelto hate factor. And then those we weigh against each other, we discuss it with the patient, come to a conclusion we can stop after 3 or 6 months, or we continue long-term. And long-term typically means for years to come, but we revisit it once per year because we rethink new risk-benefit ratio, new studies, etc. And then the long-term damage from a blood clot, I had already shown you the pigmentation. I've used the term post-thrombotic syndrome. That's what this is after DVT: chronic swelling, chronic pain, pressure, heaviness, tightness, leg tiredness, skin hardening and itching, dark pigmentation, some spider veins, and in the worst case, skin breakdown or ulcers. That does not happen in many people, but in some people it does happen. In compression stockings, they don't prevent the post-thrombotic syndrome. They just help as long as you wear them. They squeeze out the fluid. So if a patient has swelling, the stockings are often beneficial. But some people say they're uncomfortable, they are heavy, they put tightness, they cut into the soft tissue. Then our comment is don't wear them. It's really up to the patient. If they feel comfortable with them, they make them feel better, obviously wear them. But if they make you feel worse, don't wear them. Medically, it does not matter to treat the symptoms of post-thrombotic syndrome. And sometimes, if there is a significant post-thrombotic syndrome, we look for some narrowing, some scar tissue in the leg that potentially one could balloon and stent so that the blood outflow is better. There's also congenital narrowing in this area that's called May-Thurner syndrome, that sometimes we want to stent to open up the veins and drain the leg. So that is the treatment and what to expect. And I'm going to show this slide, and I have a couple of more topics briefly about research. And I'm not talking about, or I have not talked about unusual clots, but the hematologist sees them. They're not common, and the treatment is very individualized. And those are clots around the brain in the veins, in the eye, maybe in the abdomen, so-called portal vein, splenic vein, mesenteric vein, in the kidney vessels, or in the ovarian vein, and then a disorder in the skin, where skin vessels thrombose and lead to deep skin ulcers that are very painful. I'll mention that because I have a research interest in that. And then some people have unexplained arterial events, not the ones with obesity and smoking, high blood pressure, diabetes, but a 32-year-old healthy person who develops a stroke, maybe due to a clotting disorder. Those are not the topic of today's discussion, but are important for what we see in hematology. And Kevin and Nate, I'll stop there for a second and see, are there any questions about this part, diagnosis and treatment it was?
There are no questions in the chat box, so I think we can go on.
All right, so then research. This is the skin disorder, and I only show you one slide. There's no disorder in hematology in my practice, and I've been at UNC now for 22 years, and I see a lot of patients with thrombosis. There's no disorder that has frustrated me more than this disorder called livedoid vasculopathy. And that's skin ulcers, and you see that this patient has deep ulcers in the skin, and they're extremely painful. And when people biopsy them, it's due to blood clots in the vessels in the skin. And since the leg often, as here, looks bluish livedoid, it's called livedoid, the blood vessels are involved, vascu, pathy, it's sick, or it's ill, vasculopathy. It doesn't really have the word thrombosis in it, even though that's what it is. And it's not due to a vasculitis and inflammation, such as what people with lupus or rheumatoid arthritis or other inflammatory disorders have, or in vasculitic problems have. It's just thrombosis, and we don't know what causes it. There's another disorder that has a similar name, confusing. It's not the same as livedoid reticularis. And when the ulcers heal, they heal up with white scars, this one right here. So that's referred to as atrophy blanche, as a French term. We don't know what causes it. How would you treat? Well, it makes sense to put the patient on blood thinners. We do that. Sometimes it helps, but then it comes back in spite of blood thinners. Maybe we add aspirin. And then people have thought maybe it's an immune mechanism, inflammatory, without the vasculitis part, the inflammatory cells that you see on biopsy. So people have used other medications, immunoglobulin or immune suppressants called rituximab, etc. But the natural history of this disease is that it fluctuates, and you treat, and they may still get worse in spite of the treatment. So I'm not sure those treatments really help. In some people they do, but not necessarily. So I would really like people to find out, us to find out what causes this disorder. And it's frustrating because you have a patient who's in significant pain that influences their lifestyle, and you don't really have good answers what causes it and how best to treat it. So I'm working currently with a junior person, Dr. Eswaran, a UNC resident, on a research project pursuing one possible cause why this might be. And maybe it will give an answer, but maybe not. There's so many potential abnormalities that could cause this. It would be great if somebody more junior took this up with Dr. Eswaran, Harish is his name, and we work together on this. But that's one of my 5-year, 10-year goals in my professional life, to sort out what causes this so that we can offer some good treatment. And then I take an interest in high-level athletes. And those are people who have blood clots, who need to be on long-term blood thinners, but they have a profession or a big hobby of contact sports where they cannot be on a blood thinner. And that's a problem. The football player, NFL player, or the NBA player who needs to be on long-term blood thinners, but also for people with their hobbies. And at the moment, this is not a research project per se. It's more a clinical service that we offer. And that's a sports medicine colleague of mine, Josh Berkowitz, and myself. He brings the sports medicine perspective. I bring the hematology thrombosis perspective. And it started about 8 or 10 years ago with a NASCAR driver. And this is public knowledge. It's not HIPAA protected. And he needed to be on long-term blood thinners, but he could not be because those people sometimes crash and you don't want to be on blood thinners. So they need to stop blood thinners before that they race. And the first thing that we ask, and I'll make this really brief, in people who have blood clots, what other risk factors for clots does the athlete have other than hormones and family history, etc.? And there are some typical things that put baseball players, for example, at risk for blood clots in the arms, called thoracic outlet syndrome, or maybe NFL players who have big calf muscles, popliteal entrapment syndrome, or bicycle racers who are bent over, they develop groin clots and may have a pre-existing May-Thurner syndrome. And some people take illegally testosterone steroids for muscle building. But then there are other reasons why athletes may have blood clots. This is a patient who had a blood clot in his big vein in the abdomen. This is the clot. And you wondered why? Well, he wears a weightlifting belt that compresses the abdomen and distorts this big vena cava and predispose him to clots. And then sometimes people use these metal rollers as a myofascial release. They do that pretty hard, and it can lead to superficial thrombophlebitis. And you wonder whether dehydration plays a role, et cetera, et cetera. So you want to identify them. NASCAR, those people get quite dehydrated. So you define the clot, you list the risk factors as in any athlete, and then you make a decision, is it a transit risk factor associated clot, stop, when some people need the long term. And when it's long term, the nice thing about these DOACs, Eliquis and Xarelto, is that they're out of the system within 36 or 48 hours. But the metabolism is somewhat different in individuals. Some people peak rapidly and high, others peak less. And in some people, the drug is more quickly gone, and others it's more slowly. So if you tell the athlete, well, stop the blood thinner a day before your contact sport, the NFL play, well, they may still have some significant blood thinner on board, whereas the other NFL player may not. So what we do in our clinic, in our program here, is individualized pharmacokinetic studies or pharmacodynamics, where after the intake of Xarelto or Eliquis, we measure the blood level of the drug at certain time periods over 24 hours, and we see how quickly the drug disappears. And then we can tell the athlete, you fall into this group, and within 16 hours, most of the drug is gone. So you skip the morning dose, and then you can embark on a contact sport 16 hours, at least 16 hours, well, 16 hours or more after the last drug intake. That allows individual dosing regimens, and some professional athletes, and increasingly college athletes are coming through our clinic because there are just so many college athletes that can continue to do their sport even though they're on a long-term blood thinner. And we've published on that, and you can download that if you like. And I will also make these slides available to Kevin, Nate, and Zach if you want to pass it on to people. So then, oops. What we don't know is what is a safe drug level. So we've really aimed at a very low level that we, in discussions with multiple experts in our field, have thought is safe, and we've gone even a little lower. And that's the level where we then say to the athlete, likely this is a safe level to participate in your sport. So then they start the blood thinner again after the game if they didn't have any major trauma. But if trauma occurred, then the sports medicine physician needs to assess, and the athlete needs to assess, when do we start the blood thinner again? Do we wait a day, et cetera? And then needs a team physician evaluation. It's not easy. There's certainly some hurdles. It's not available for every, not a middle school or high school student who don't have the sports medicine support and the team support. And we've developed some tools that we've published that people can use, and that's being used in some of the colleges. So that's Josh Barkowitz. It started actually 12 years ago with a NASCAR driver, went through an NBA player, through multiple now individuals and patients that we've seen with publications. And I want to take this a step further. I'm currently writing a case series on the cases we've seen, and we need to get to the point where we have collaborations with more MD, PhD minded people, sports medicine, to think about who are the people who clot. It's not common in athletes, they're typically young, but to find some ways to get also the research going that eventually we can avoid blood clots. So I've talked about being a coagulationist. And finally, why is it interesting? It's not just because it's so multicolored and you're involved in so many people. It allows me to give the talk to you, to interact with you. That's nice. It's enjoyable. I got called by the Duke Lemur Center. The lemur had a blood clot in the leg. And the veterinarian called us, did not call Duke, by the way, called us at UNC. And Charlie actually was thought to have a leg clot because it had a lame leg. He was not using the leg after surgery. Eventually, a Doppler ultrasound showed he did not have a blood clot. It was something else and thought to be a septic arthritis, maybe. But we gave advice initially for a formal ultrasound. We looked at if there is a clot, really, what dose of a blood thinner do we use? We eventually were invited by the veterinarian to tour the Duke Lemur Center. Highly recommended, probably not possible at the moment with COVID. and we visited Charlie. And I wrote about Charlie in the more lay publication. There are 2 publications which are brief and fun, I think fun to read. Yeah, Charlie eventually had to be put to sleep because his lame leg was migrating to the other side, then the arms were involved, and then he could not, what the veterinarians call locomote, which is climb and walk around. So they eventually had to put him to sleep. They wrote me a really sweet thank you note from the Do Clots Center, and I've written about that because it really moved me. One of the best things in medicine is the individual contacts we have with patients and thankful patients who are family members where you really had an impact. And finally, some of you may know, and this has also been a coagulation with thrombosis. A little while ago, I was called by NASA to take care of an astronaut on the International Space Station who had a blood clot that was discovered in the left internal jugular vein. Was discovered incidentally because they were doing a study in space of blood flow abnormality in space, because blood flow in 0 gravity goes to the head. And they discovered a clot that was asymptomatic, no symptoms. But the question was, do we put the person on blood thinners? And we did, because the risk is that the clot gets bigger and it goes into the brain and the sinus vein thrombosis, or it breaks off, or it goes down further and breaks off and causes a PE. So blood thinner was used. We assessed the risk for bleeding to be low. The astronauts are typically young. They don't bang themselves in 0 gravity. They float slowly. And the astronaut did well and remained asymptomatic. And eventually, after return to Earth, the clot was gone. We've published on that. It's available in the New England Journal of Medicine. And you can download that here. It's a fascinating case. I don't know whether you've ever drawn up a fluid in space, like Lovenox, a syringe, a blood thinner. Fluids in space, they are just droplets. So in a glass vial, it took the astronaut 20 minutes to get every single drop of blood into the syringe and then inject it into the skin. They didn't have an oral agent. And then the astronaut ran out of the needles and the syringes, so had to go over to the Russian unit and get all the needles that they had. And they were large size. They were 18 gauge, if you know what size that is. They're big. You don't want to jab that into your skin once a day. So eventually NASA shipped up some oral anticoagulant, Eliquis. And one of the nicest things was I was invited to Houston to talk about what do we test for in these astronauts in the future to detect, do they have clots, clotting disorders, what medications do we need to have on board when we fly to Moon and Mars. And the astronaut actually gave me as a souvenir some Eliquis tablets that have been out of space. I think I'm the only one who has Eliquis that's been out of space. With that, I will finish. This is all I had to talk about. Well, all that the time allows. Thank you very much, everybody, for your attention. And maybe we have time for questions. Kevin, Nathan?
Yes. Thank you. First of all, thank you, Dr. Moll. That was wonderful. That was a great talk. I learned a lot myself, and I've been to medical school. So I'm hopeful everybody in our audience also learned quite a bit. We got a first question from Ms. Hummel. Nope, not a question. She just says, thank you very much for answering all of her questions. And that was a lot of information.
Awesome. Hope you do well. If you need a hematologist, not that I'm looking for business, not at all. I tell you, Duke has lost 5 hematologists, and all the Duke patients are coming over to UNC. They do not take any new patients anymore, so they all come in here. So we have a wait list. But if you want expert input into clot management, our group, and there's several of us are available. And if your clot was fairly recent, Cassie Frank is the DVT walk-in clinic person, the PA, who's superb, and she'll take care of you.
All right,
I imagine you can Google UNC DVT walk-in clinic to find that.
You probably can. I have done this in the past.
All right, but we do have one question in. And this is going to be a little bit more research forward-looking related. What is your opinion on using the adeno-associated viruses for factor VIII gene therapy for hemophilia A and other genetic diseases?
I'm not a good one to talk about that. I'm an interested bystander, but not involved in that, so it would not be meaningful what I have to say. This would be a question, whoever asked that and who has interest in that. Nigel Key, K-E-Y, he's our section chief and leads our hemophilia and thrombosis program. And we are involved in our hemophilia center with gene therapies. So he would be the one to talk to. And if this is from an MD PhD student, he would be the one to talk to about getting involved in any of the researches as well.
That was a great question.
Yeah.
I don't see any more questions in the chat. And because it's after 8, I think we can end the session here. But before we go, I do have one question that's killing me, Dr. Moll. Was that that clot in space, was that the first ever recorded clot in an astronaut that happened in space?
It was, Nathan.
That's
and
insane.
then I will add a little comment. When NASA called me and asked for advice, I said, I don't give advice unless I examine the patient. Can you fly me up there? And what they said, truly, let's see what we can do. But in between, can you tell us, etc.
That's wonderful.
And then the second good story was the astronaut called me because after all, the astronaut was a patient who eventually had some questions. So called me at home on a Sunday. It was prearranged, and my wife picked up the phone. And on the call identifier, it says International Space Station. So she held up the phone and said, Stefan, there's a call from outer space for you. True story too.
That's wonderful. Oh my gosh,
stuff.
that's so great.
That's great. All the fun stuff you can do, from
Yes.
lemur centers to astronauts.
And particularly since the outcome was good, right? So we can now can talk lightheartedly about it.
Yeah.
Wow. Well, thank you all for attending.
Thank you. Thank you for everyone who attended. We'll try to get these lectures up online shortly, along with the slides. We had some trouble on the website backend, but we're working to resolve that. Thank you, Dr. Moll, for all of your time tonight. We really appreciate it. And this was a wonderful talk on clotting and what we can do about it. And I think your program is an incredible resource for both people on the medical side of things and for patients.
My pleasure. Thank you, Kevin and Nathan.
Thank you.
Have a great night, everyone.
Yeah, see you all next week. What is our topic next week, Kevin? It is
Chronic kidney disease.
Chronic kidney disease. All right. Have a good week.